Hello, this is Elise. I am doing my case study on pneumonia. My patient is Connie Brown. She is a 77-year-old female. She's arrived at the ED with the following symptoms: a fever of 38.1, an increased respiratory rate of 24, a productive cough, a dyspnea, chest pain, and fatigue. She has a past and regular history of atrial fibrillation and asthma. She is retired and lives at home with her husband. Her diagnosis is a bacterial lower lobar community-acquired pneumonia. So what is pneumonia? Pneumonia is an inflammation of the lung parenchyma caused by bacteria, mycobacteria, viruses, and fungi. The general term that describes the inflammatory process in the lung tissue is pneumonitis. This is a predisposition to microbial invasion. Pneumonia has a significant rate of morbidity and mortality. When older adults are admitted to hospital with pneumonia, they can develop significant disability and reduced functionality. So that would be related to Connie, as her age is 77. Underlying pathophysiology of Connie's case, the upper respiratory tract protects the lower respiratory tract, which is sterile. From potential infectious pathogens, people whose resistance to infections has been compromised due to aspiration of the flora which it resides in the oropharynx, which is its reservoir. Pneumonia has an effect on ventilation and diffusion. An inflammatory reaction can occur in the alveoli, causing the production of exudate that interferes with the diffusion of oxygen and carbon dioxide. The white blood cells, mostly made up of neutrophils, migrate into the alveoli and fill the spaces which normally filled with air. Areas of the lung become inadequately ventilated because of the secretions and the mucosal edema. When they cause partial occlusion of the alveoli or bronchi, causing a decrease in alveolar oxygen retention. Hyperventilation can occur when a perfusion mismatch occurs in the affected areas of the lungs. Venous blood that enters pulmonary circulation passes through the underventilated area and travels to the left side of the heart, poorly oxygenated. When oxygenated and poorly oxygenated blood mix together, this can cause arterial hypoxemia. Due to these physical changes, the patient's respiratory rate will increase in an attempt to improve their oxygen levels. This can eventually lead to the patient becoming exhausted from the tachypnea, causing the respiratory rate to then decrease, which then can cause the hypoxemia. So there are 4 classifications of pneumonia. I'll mainly focus on community-acquired pneumonia because of Connie's case. So the community-acquired pneumonia is a type of pneumonia that occurs in the community or less than 48 hours after being admitted to hospital. The most common route community-acquired pneumonia is contracted through is the lungs by aspiration into the upper airways. Can be either bacterial or viral. The most common bacteria causing this type of pneumonia is Streptococcus pneumoniae, which is responsible for 20 to 60% of the cases. This bacteria only affects humans and is found in the nasopharynx, which is its reservoir. It's a gram-negative and encapsulated bacteria, which makes it harder for phagocytosis to occur because of the encapsulated. Healthcare-associated pneumonia is described as pneumonia occurring in non-hospitalized patient who has had extensive contact with the healthcare system. The other type is hospital-acquired pneumonia that occurs more than 48 hours after being admitted to hospital. And the last one is ventilator-associated pneumonia, which is described as a type of pneumonia that occurs more than 48 hours after being intubated. Other classifications for anatomical lobar pneumonia, which is what Connie has, is diagnosed when a substantial portion of one or more lobes is involved. With the red blood cells present in the exudate, a rusty colored sputum is produced, which Connie has, typical of lobar pneumonia. In lobar pneumonia, the adjacent pleura infected of the affected lobe are infected by inflammation. This is known as pleurisy, which is what's causing Connie's chest pain, and this occurs in the anterior or posterior chest wall. The infection spreads into the pleural space, causing empyema, which is a pus collection in the pleural cavity. Other types include bronchopneumonia, which is actually more common than lobar pneumonia, bronchial pneumonia, and round pneumonias, which is actually more found in children. Another type of pneumonia, just to touch on, is aspiration pneumonia, which can be acquired in the community of the hospital. It is caused by aspiration of oropharyngeal, nasopharyngeal secretions or the vomit when it is inhaled into the lower respiratory tract, causing irritation to the tissues. It has actually a higher mortality rate than any other type of pneumonia. Signs and symptoms can vary based on the type, anatomical location, and the patient's current health situation. So dyspnea, shortness of breath, and orthopnea, which is shortness of breath when reclining. Persistent cough, either with non-productive or productive sputum. Pleural chest pain, causing restricting chest expansion, fever, rigors, chills, night sweats, nausea, vomiting, diarrhea, change in mental status, fatigue, a poor appetite, and worsening of chronic health conditions. The risk factors is quite extensive. I have narrowed it down. Respiratory conditions, so one has the asthma and cardiovascular disease, so she has sexual progression, which has definitely increased her risk. Chronic liver failure or disease, chronic renal failure disease, and dialysis, neurologic disorders, cancers, immunocompromised, younger than 2 years old, older than 65 years old, is because they have a decreased cough reflex, increased potential for colonization of gram-negative organisms, and a decreased immune response. Altered mental state, being male, malnourished, obesity, pulmonary edema, diabetes, uremia, and those currently already taking antibiotics for another infection. Other things can include smoking, high alcohol consumption, exposure to toxic inhalants, chronic steroid use, homelessness, and living in an overcrowded situation. Potential complications include sepsis. This is a medical injury and requires really prompt treatment. This is when the blood infected with bacteria then can spread to other organs, causing other infections such as meningitis, peritonitis, endocarditis, and septic arthritis. Sepsis can develop into severe sepsis, and this is considered when at least one organ shows signs of failure. Prompt antibiotic therapy is to rapidly reduce the bacterial load, and downgrading the initial inflammatory response reduces the risk of developing sepsis in the first place. This can lead to septic shock. This is a complex form of shock caused by bacterial that invade the blood. Septic shock is more likely caused by a respiratory or gastro infection. Septic shock occurs when the dysfunction of the immune system has the initial inflammatory response to the infection is considered to be excessive, prolonged, and leading to tissue damage. Another one is respiratory failure. This results when a patient's oxygenation falls below 60% on room air. This happens when the respiratory system is no longer able to meet metabolic demand. Another one is pleural effusion, is the accumulation of fluid in the pleural space between the visceral and parietal pleura. Pleural effusions develop as a result of excessive fluid production or from decreased absorption. They are commonly classified by this type of fluid in the pleural space, either transducive, which is caused by non-inflammatory processes, or exudative, caused by inflammatory processes, which is what Connie will have. A lung abscess is also another complication. Is a pus-filled cavity that forms inside the lung tissue. Lung abscesses usually develop in patients who have underlying illnesses or have a history of alcoholism. Signs and symptoms include coughing up unpleasant sputum, smelling sputum, having edema in fingers and the toes. So for nursing management, I will definitely carry out a physical assessment of the cardiovascular system, so perfusion and capillary refill and heart rate. For my respiratory assessment, to check for oxygen saturation, fatigue, tachypnea as a result of using of accessory muscles to breathe, bradycardia, coughing, and purulent sputum. Continually checking her temperature, her pulse, the amount and the colour of the sputum she is coughing up, and the severity of the cough, the degree of tachypnea and the shortness of breath, and any other changes in physical assessment. Also, just assess the skin for dehydration, her mental status, appetite, and if she's having any falls. And in particular for Connie, this will include checking in her changes in behaviour, mental status, dehydration, excessive fatigue, and concomitant heart failure. That will need to assess. My interventions will include maintaining airway patency, breathing exercises such as deep breathing, effective coughing, and using a spirometer to encourage lung expansion, improve gas exchange, and reduce dyspnea and reduce other pulmonary complications. Oxygen therapy can also be beneficial. Symptom management, so managing the pain and fever, using oxygen bronchodilators to relieve respiratory symptoms and sometimes cough presence. Promote fluid intake, because the increased workload imposed by labour, breathing and fever, the respiratory rate increases. So because of this increased rate, there's an increase in insensible fluid loss causing during hydration, which can cause dehydration. Nutrition. Many patients with pneumonia will have decrease in appetite because of the shortness of breath and fatigue, and may want to have fluid intake. So I would want to encourage Connie to have maybe nutritionally enriched drinks such as shakes that could be beneficial, and if absolutely necessary, we could give her IV fluids and nutrients maybe can be administered that way. Early mobilization. Getting Connie moving early would be ideal because it is able to improve her functionality and clear sputum and prevent atelectasis. The benefits of early mobilization include reducing muscle weakness, microvascular dysfunction, deconditioning, physical activity intolerance. And sitting on a bed is also very beneficial, and may reduce, this early mobilization may reduce the length of stay. And lastly, I will do education. This is telling her husband about the causes of pneumonia, how to manage. Her and her husband will know the signs, symptoms, and what they need to tell the staff. Risk factors, what recovery will they involve, so tiredness, feeling weakness for long because of her age. To keep encouraging her breathing exercises even if she's discharged home. Medication education about the antibiotics and things like that, and the importance of follow-up care such as going for x-rays and visiting her doctor in post follow-up appointments. And my reference will be attached.